I'd like to spend a little bit of time talking about how the management of colon trauma has changed through the years. I have no conflicts, and yes, our trauma center really is named the Elvis Presley Memorial Trauma Center. A bit of trivia, just in case you ever get asked, the Elvis Presley Memorial Trauma Center remains the only freestanding building in the entire world named in honor for the King. So there you have it. First, just a bit about Dr. Sherman, and I'm very appreciative to have this honor to give this lecture in his name. He received his MD degree from the University of Cincinnati and then did a stint at Walter Reed Army Medical Hospital. Some of y'all may have heard of that. He then left Walter Reed and came to UT in Memphis at the time and had a keen interest in both trauma and burn research, but primarily in helping the residents. From there, he went to South Florida, where he became the first chairman of the Department of Surgery, and after he left there, he went to Grady and ultimately rose to become the chief of surgery there. But I suspect that his greatest contribution is his multiple teaching awards and his dedication to the training of the residents. And for the house staff that are here and the young surgeons, he was the epitome of being able to figure out a question and then figure out a way to answer the question and then write a paper about it. So that's really the way that we need to approach clinical research today. The first report of a colon wound was from the book of Judges in the Bible. And I'll spare you with reading the passage, but a couple of interesting things about this passage. One may think, how could somebody get in to see the king with a sword, right? Especially someone who was a known enemy of the king. Well, Ehud was left-handed. And back then, most people were right-handed, as they are today, and so a right-handed person would have their sword on their left hip. So the Secret Service for the king patted down Ehud's left hip. Ehud was left-handed, so his sword was on his right hip. So he was able to come in and stab the king, and lo and behold, the description of his colon wound was then memorialized. The king did poorly after this particular wound, and there we have it. Since that passage in the Bible, very little was written about the management of colon injuries up until about the Civil War, and really there wasn't a whole lot done with patients with colon injuries in the Civil War, which some may refer to as the War of Northern Aggression. But these penetrating wounds were primarily managed non-operatively, and the few that survived really only survived because they developed an intercutaneous fistula, which basically was a functional colostomy. Attempts at surgery during that period of time were almost uniformly met with fatality for all sorts of different reasons, but nonetheless, it was decided then that patients with colon wounds really shouldn't get operated on, because if they developed a fistula, then they had their best chance of survival. But if you operate on them, then they all died. In World War I, there were a few changes, most of which were for the bad. One is that we now had higher velocity missiles, which caused more tissue destruction. But the primary care really did consist of expectant management. Towards the end of the war, more people got operated on, and the mortality rate dropped from 90 to 95% down to about 65 to 70% or so. It's an improvement, but really not that great of an improvement. So I think from this early data, we can conclude that non-operative therapy doesn't really work very well for patients with colon wounds. World War II came about with the advent of penicillin, the advent of aggressive resuscitation, improved antibiotics, and blood banks. And then there was one other minor thing and that was the exteriorization for all colon injuries. I think penicillin actually helped for a lot of things in World War II, not the least of which was colon injuries, but nonetheless, Major General Ogilvy, who was a British surgeon who was in charge of the European theater, basically put out the mandate that all soldiers who had penetrating colon wounds must undergo exteriorization of the wound, or colostomy. I find interesting is that others have died who would still be alive had they fallen into the hands of a surgeon with less optimism and more sense. The Brits had a way with words. But nonetheless, everybody got a colostomy, and in fact, if a surgeon was found to have performed a primary repair on a patient, then that surgeon was a candidate for being court-martialed. Pretty aggressive therapy, but the mortality rates dropped to about 30% with this. So at least in World War II, mandatory colostomy was better than no operation. So mortality goes from 70% down to 25 to 30%. Pretty good improvement over time. So during the post-war period in the United States, then the wartime practice of exteriorizing all colon wounds then was adopted in the U.S. And so every patient who got shot in the colon got a colon wound. But Woodall and Oxer in New Orleans realized that the weaponry was a little bit different in New Orleans than it was in the European theater. And they realized that not everybody needed a colostomy. So people, at least during this period of time, tended to get shot with either a shotgun or 22s or 25s, lower velocity weapons, not like what we have today. But so they realized that not everyone needed a colostomy. So they wrote this paper about primary repair. And so intermittently, over the next 25 years or so, there were some surgeons doing primary repair for very simple wounds, especially patients with stab wounds. But in general, colostomy was the way to go, except in very selective patients. And then came this landmark paper by Harlan Stone and Tim Fabian at Emory in the late 70s, where they performed the first randomized trial between patients, for patients with penetrating colon injuries, between primary closure and colostomy. Because of the radicalness of this particular concept, they did set aside specific criteria for obligatory colostomy. And basically, these are patients who were really sick or really lost a lot of blood, had a lot of contamination, had a prolonged time to operation, and had a destructive colon wound so that it required resection. What they found was that the overall infection rate for patients who were randomized to primary repair was significantly less than those patients who were randomized to colostomy. In fact, the randomized colostomy group had similar complication rates than did the obligatory colostomy group, which is a group that you would expect to have the highest complication rates since they were the sickest group of patients. This was somewhat this was a practice-changing study, although many surgeons realized that this, in essence, could be interpreted as heresy by not exteriorizing wounds. However, it was pretty clear that for simple wounds to the colon, that primary repair could safely be done to these particular patients. But the problem is what identifies a high-risk patient, right? Who would benefit from colostomy and not necessarily a primary repair? So when Fabian moved to Memphis, he began a study for primary repair of colon wounds in non-selected patients. Pretty radical at the time, but looked at 102 consecutive patients who had penetrating colon injuries, and they were all closed primarily regardless of shock or contamination or associated injuries. 83 of these 102 underwent primary repair, and 12 patients had resection and anastomosis. One of those patients suffered a leak. 7 wound up with end colostomy, primarily due to massive destruction and abbreviated laparotomies. So what they found was that transfusions, significant contamination, and increased severity of colon injury were all independently associated with intra-abdominal infection, but not suture line dehiscence. Okay, there's a difference. So significant contamination, multiple transfusions were all associated with abscess, but not suture line failure. And concluded from that data that nearly all injuries could be repaired either primarily or with resection and anastomosis. So I think from this data, we can conclude that primary repair is best for non-destructive wounds. Okay, that's pretty straightforward and that's pretty simple, and that's really the way it is today. Someone with a simple colon wound, they get a primary repair and go on about your business. One of the things, and I'll say this for the residents in the room, that if you're sitting in a hotel room, I don't know, maybe taking a test or something, and if you happen to get me for the exam, do not say, because of massive contamination, I'm going to do a colostomy. If you do, maybe you'll do better the next time you're sitting in that hotel room. I don't know. So now, what about patients who have destructive wounds, and should they undergo resection or not? Chapuis, again, out of Louisiana, stated that based on a fairly small series, said that you should do either primary repair, resection, and anastomosis for all patients. However, this generalization was made on a fairly small number, only 11 patients who received a resection and anastomosis. 11's kind of a small n to make such a broad statement, but nonetheless, that's what he said. So really the question still does remain, who should get resection and anastomosis in patients with destructive colon wounds? Who is it safe to do resection and anastomosis? And then who is it safe and really better for the patient to go ahead and perform a diversion? Here's a simple, post-breakfast colon wound that really adds little to the talk, but I just sort of like seeing it. So what about, how do we define destructive colon injuries? Well, if you got a wound that encompasses greater than 50% of the wall, a complete transection for obvious reasons, or a devascularized segment, especially with associated mesenteric injury, which you wound up is going to require resection. Well, Ronnie Stewart, when he was a fellow in Memphis in '94, looked at 60 patients who had destructive colon injuries. And really, we kind of stumbled upon this and found that patients who had a destructive colon wound and multiple transfusions, greater than 6 units of blood, or significant medical comorbidities, okay, so medical comorbidities or multiple transfusions, if they underwent resection and anastomosis, we had a 42% leak rate. If they had a destructive wound, received less than 6 units of blood, and were otherwise healthy, there was only a 3% failure rate. And this was pretty important at the time. And what we defined with this particular study was these were the significant comorbidities. And if you look at these are all really patients that these are all really diseases that render the patient with a relative immunocompromise. And if you add this relative immunocompromise to multiple transfusions, which are known immunocompromisers, then it's not particularly surprising to see how patients will have higher leak rates if they have all these particular things. And so came up with this particular algorithm for patients with full thickness colon injuries. If it was a non-destructive wound, they undergo primary repair. That's it. If it was a destructive wound, if they had a significant medical comorbidity or received more than 6 units of blood, they underwent fecal diversion with colostomy, either an end or a loop. If they did not have significant medical comorbidities or less than 6 units of blood transfused, then those patients underwent resection and anastomosis. And that then became our management algorithm based on the results of this particular study. Others including this group from the left coast, looked at suture lines, and basically this group, the group from LA County, said that there's still room for fecal diversion in patients with high-risk categories with destructive colon wounds. And this basically corroborated the data from the Memphis. Well, Preston Miller, when he was a fellow at our institution, looked at the next, after Stewart looked at 60 patients, Miller looked at the next 56 patients with destructive colon injuries, and with more adherence to this particular algorithm, right? Before we stumbled upon the algorithm, now we're actually trying to follow it, found that intra-abdominal abscess rates, suture line leaks, and overall colon-related mortality all decreased significantly over time. Dimitriadis, in a study that was done published in the Journal of Trauma in 2001, looked at 300 patients from 19 different centers, all of whom had destructive colon injuries, and did a regression analysis and basically found the same sorts of things that have been described in the past. Multiple transfusions, a large amount of contamination, and inappropriate antibiotics were all independent predictors of intra-abdominal abscess. Not necessarily suture line leak, but intra-abdominal abscess. This study had really some problems. Number one is they concluded that transfusions were independent predictors of complications, but didn't really use that in their algorithm. But more importantly, is they looked at 19 different centers, and it's really hard to control 19 different centers, all of whom had multiple different surgeons performing these procedures on multiply injured patients. So it's really kind of hard to put all that together, especially if there's no standardization preoperatively on anything to do. So while it was a very important study, it has, like many studies, it does have its drawbacks. So after the 50 or so patients that were published before, we then looked at about a 15-year period, a 15-year group of patients, all of whom had penetrating colon wounds, found 250. And the interesting thing on this is we looked at 3 different time periods, and note that destructive injuries go from 19 to 27 to 41% over time. And I think that's indicative of the change in weaponry that at least we're seeing in Memphis, and I'm quite certain that that's being seen throughout the country, that no longer are patients getting stabbed or shot with low-velocity injuries. Now patients tend to get shot with much higher velocity injuries, which cause much more tissue destruction, which then makes the whole concept of what to do with a destructive colon injury even that much more important to try to figure out what to do. So Sharp in 2012 looked at the next 100 patients. See, it didn't take us long to get 100 patients with destructive injuries, and with far more attention to detail relative to that particular management algorithm, found continued decreases in intra-abdominal abscess rates, colon leak rates, and overall mortality. And in fact, we got up to 90%. The truth is, you'll never get up to 100% for algorithm compliance, because you don't know some patients, they're not able to really talk when they come in. They're either unstable or they don't want to talk. Why they wouldn't want to talk to Mr. Congeniality, I'm not quite sure, but nonetheless, some patients don't really want to talk or tell you about their diabetes or about their HIV. They don't want to. So compliance will never really be 100%, but nonetheless, for these 100 patients with destructive injuries, if we follow the pathway, our leak rate was only 3%, very similar to what Stewart originally described 15 years earlier. And in the protocol violations, the leak rate was 30%. So again, this algorithm seems to be pretty durable over time, at least in the management of penetrating destructive colon wounds. So from this data, then I think we can conclude that this algorithm is in fact pretty successful. Now, there has been a fair amount of debate as to the management scheme for injuries to the left colon versus injuries to the right colon, and that should they be managed differently because the colon wall is different, the character of the stool is different. There's all sorts of things different, the blood supply and so forth. So is it safe? So we tried to look at this anatomic distinction, and a lot of it is based on the tenuous anatomy, especially around the splenic flexure, and that most of these previous reports have really only focused on right-sided injuries. A group from Denver in '81 looked at 105 patients, and they found no differences in outcome relative to either right or left-sided injuries. Dente from Emory looked at had 217 penetrating injuries, and it was really pretty interesting. They had 7 suture line failures, all about the splenic flexure, all in the watershed area around the splenic flexure. And so really what they concluded is that if you're going to resect and do an anastomosis around the splenic flexure, you better really be very careful because that's got the highest leak rate. There may be some selection bias in this particular study, but really all the managers, if you're going to have interpretable data, all the injuries really need to be managed the same so that you can figure out exactly what to do. So again, John Sharp presented this data at Western Trauma, looked at patients over a 13-year period, looked at location of colon to see if that really impacted. So there's 470 patients, a third of them had right colon injuries, 30% transverse, and another 35% had either descending or sigmoid colon injuries. And if you look at the outcomes, the abscess rates are relatively similar, leak rates are relatively similar, and overall mortality was likewise relatively similar. And if you adjust, in doing logistic regression and the adjusted odd ratios, you can see that all of these cross 1, so therefore there's no significant difference between location of injury and the development of either intra-abdominal abscess or for suture line failure. So I think from this data we can conclude that the injury location really doesn't matter and that all these colon wounds should be managed as colon wounds, and right, left, transverse, sigmoid doesn't really matter. Notice I'm leaving out rectal injuries, although frankly intraperitoneal rectal injuries can be managed in a very similar way that the rest of the colon. Extraperitoneal rectal injuries, little different story. So what about patients with blunt colon injuries? Luckily, it's a fairly unusual occurrence because these can be particularly devastating injuries. They're typically associated with significant mesenteric injuries as well. So what looks like a clean resection at the initial operation may not necessarily be so clean when that patient falls apart in about 5 days. So patients with blunt injuries are a very different animal. So we tried to look at that, and again, that's sort of the blessing and the curse of living in an area where you've got a high volume trauma center. So we were able to look at patients with blunt destructive colon injuries. And this involves serosal tears greater than 50%, or somebody with a devascularized mesentery, and obviously full thickness perforations. So over the study period of time, we had 150 patients who had blunt colon injuries. And with this, we had 95% algorithm compliance. And it's not particularly surprising that the compliance would be a little bit better with these patients because they typically, they tended not to come in hemorrhagic shock, so they had time to go ahead and get a preoperative evaluation, and hopefully they were a little bit more likely to talk. At any rate, of these 150 patients, 143 followed the pathway, and if they follow the pathway, the leak rate was just under 2%. If they didn't follow the pathway, in the 8 patients with protocol violations, the leak rate was 10 times higher. At 13%. So from this data, we think that this algorithm, notice a recurring theme here about this algorithm, that it's also successful for patients with blunt colon injuries. So not only is it successful for any penetrating colon injury, it's also successful for blunt. So it's really proven, this particular algorithm is really proven to be quite durable through the years with all different types of colon injuries. So the last frontier really is patients who have open abdomens. At some institutions, the presence of a midline incision is an indication for leaving them with an open abdomen. We try not to be quite as aggressive with that, but it's pretty clear in looking at these particular wounds that there's no way you're going to be able to, even if you had a winch in trying to close the abdominal wall and crank it together, it's not really going to work. So what do we do in this situation in patients with colon injuries? Well, the group from Wake Forest looked at 22 patients with open abdomens, and 11 of these patients underwent segmental colon resection as part of an abbreviated laparotomy, and then had a delayed colonic anastomosis. So they had resection and anastomosis, laparotomy one day, anastomosis 2 days later at the time of re-expiration. And from these 11 patients, they had no leaks and declared that delayed anastomosis was safe in selected patients. The problem with this study is about half of the 22 patients died before they left the hospital. So it's really kind of hard to figure out exactly what happened. They didn't die relative to their colon injuries, but they died because of their other injuries. So it's hard to extrapolate from that. Weinberg, when he was at UAB, looked at 56 patients who had an open abdomen, and 33 of these patients underwent resection with delayed anastomosis. And with that, in that patient population, they had a 12% leak rate. And their statement was that the anastomosis in this setting of an open abdomen is really a cautionary tale. And that perhaps we should divert those patients because they considered a 12% leak rate too high. The group from Denver looked at 29 patients. They had a 16% leak rate, and they concluded that delayed anastomosis was safe. Despite the fact that their suture line failure rate compared to the study from Alabama was higher, they drew completely different conclusions, sort of reminiscent of the Charity LSU pancreatic resection study from the AAST many, many years ago. But nonetheless, so there's still a lot of controversy about what to do, and this is just a summary of some of the studies that have addressed patients with open abdomen who undergo resection and delayed colonic anastomosis. And we had the leak rate of 0% as described by Miller, up to the group in Nashville described a 27% leak rate. So it's really all over the board, again suggesting that these patients are very different, and perhaps if there was only a way to try to standardize the care of these particular patients. Well, what about the algorithm? Since, contrary to what Dr. Shibata said, at least in our hands, when your only tool's a hammer, everything looks like a nail. So we employed this particular algorithm in looking at patients with open abdomens who had colon injury with initial resection. Had 150 patients, 32 of these were non-destructive and managed accordingly. 117 of these were destructive wounds. 42 of those underwent delayed anastomosis. 72 underwent staged diversion, right? So they stapled off the colon, and then ultimately at the last operation underwent diversion. 2 patients had early deaths and they were excluded. 1 patient had an intraperitoneal rectal injury, and for consistency's sake, we excluded that patient as well. So if you look at the compliance on the algorithm and the no algorithm, it was about half and half, to be honest, because nobody was really quite sure what to do with these patients with open abdomens. As one would expect, the patients in the algorithm arm had fewer transfusions and were not nearly severely as injured as those not 4 units of blood versus 16 units of blood. little bit of difference between those two patient groups. But if you look at the colon-related morbidity, it was significantly lower in those patients who followed the algorithm, but admittedly were not quite as sick. But sutural line failure rates were significantly lower at 4% compared to 32%. So I'm not sure that really the controversy exists quite so much as it did before, because again, if you follow the algorithm and base the decision to perform a delayed colonic anastomosis based on transfusions and the presence of comorbidities, then one can do that with an anticipated leak rate of about 4%, which is really pretty good, especially given in higher volume or higher numbers of patients. Luckily, this is not a world health problem, so there's not a huge number of patients. And the easy thing may be to just do a colostomy on them, because then you don't really have to worry about it. But doing a colostomy on a patient with an open abdomen really presents its own unique series of logistical problems, especially if you're unable to get the fascia closed. So now the patient's got a skin graft and an ostomy and then makes abdominal wall reconstruction that much more complicated. So I think from this data we can conclude that this algorithm is successful for patients with abbreviated laparotomies. This slide lists the conclusions of the data, and again, I'll leave you with this algorithm that really can be managed. Now we can say this is for all patients with all types of colon injuries, whether it's penetrating blunt trauma or whether or not they need an open abdomen or not. So in patients with non-destructive colon injuries, those patients should undergo primary repair. It doesn't matter how many units of blood they've had. It doesn't matter how much fecal contamination they've had. It doesn't matter. If it's a simple wound, close it. If they have a destructive wound, but they do not have significant comorbidities, or they receive less than 6 units of blood, it's safe to perform resection and anastomosis. And in patients with open abdomen, it's safe to perform resection and delayed anastomosis. For patients with significant comorbidities, such as any sort of immunosuppressive disease, or if they receive greater than 6 units of blood, the safest thing for those patients is to perform fecal diversion. Now, if you want to do resection and anastomosis and then divert them proximally, that's okay too, but the key is diversion in that particular subgroup of patients. So really, the evolution of colon wound management has really gone from skillful neglect to really doing big operations. And then it went from doing big operations to doing appropriately big operations. And then hopefully now it's gone from hope-based medicine to evidence-based medicine. And hopefully we've been able to provide a little bit of that evidence here so that you can see, but it's interesting that we've gone from biblical times up until now. I do want to express my gratitude to be the Roger to give this lecture, and thank Kevin for inviting me to do this. I'll leave you. This is, in fact, the Elvis Presley Memorial Trauma Center, and I'll be happy to answer any questions.